Hello, I'm Norman Swan. Welcome to this programme on chest pain and the acute coronary syndrome. It's estimated that each year there are 90,000 episodes of chest pain and acute coronary syndrome requiring hospitalisation, and it costs both direct and indirect as much as $17.9 billion a year. And about 10,000 Australians die in the community, at home or en route to hospital with chest pain. This programme is about the latest definitions, diagnostic categories and management protocols for people with chest pain presumed to having an acute coronary syndrome. We're going out as a satellite broadcast over the Rural Health Education Foundation satellite network. You'll find that there are a lot of useful resources available for you on the Rural Health Education Foundation's website, rhef.com.au, but you're not allowed to go there just yet because it's time to meet our panel. Professor Derek Chew is an interventional cardiologist and Principal Research Fellow in Cardiovascular Outcomes Research at Flinders Medical Centre in South Australia. Welcome, Derek.
Thank you, Norman.
Sue Colby is the Nurse Unit Manager of the Emergency Department at West Gippsland Healthcare Group in Victoria. Welcome, Sue. Which town's that in?
Warrigal.
So you're in Warrigal, nice place. Yes. Barry Fukondi is an Aboriginal health worker and cardiovascular health and rehabilitation programme coordinator at Woodchopper Health Service in Queensland. Welcome, Barry.
Thank you, Norman.
Is that based in Cairns?
Yes.
But you service the Cape York
Peninsula? No, just the Cairns area.
Just the Cairns area, yep, and we'll come back to, you've got an interesting model for looking after people with chest pain, and we'll talk about that later. And last and certainly not least is Peter Joyner, who's a GP at Manham in South Australia, and is also Clinical Director of Emergency Services and Country Health in South Australia. So welcome to you all.
Welcome. Thank you.
Derek, it seems to change definition every time I look at it. What is an acute coronary syndrome?
Well, it's true that the definition of acute coronary syndromes continue to evolve as we learn more about it, and with the evolution of troponin assays, very sensitive markers of myonecrosis, that the definition of myocardial infarction continues to change. But nevertheless,
you don't need a ST elevation and ECG anymore?
No, not at all. You can certainly have lots of people who present without any changes on their ECG, but have evidence of myonecrosis as evidenced by the positive troponin, having the diagnosis of a non-ST elevation myocardial infarction. So the important thing is it remains a clinical definition. It remains a definition of based on clinical symptoms suggestive of either chest pain or shortness of breath, associated with some evidence of myocardial necrosis or under threat, your myocardium under a degree of threat from epicardial coronary occlusions.
So, when I was a lad, we used to talk about stable angina and crescendo angina. Now we talk about unstable angina and stable angina. So just pick that apart for me at the moment and where they fit into the acute coronary syndrome. So presumably stable angina doesn't.
That's correct. So we know that there are many people with narrowings in their blood vessels that cause a stable amount of chest pain whenever they exert themselves. They do the same activity every day, they get the same chest pain at the same threshold, it goes away when they stop. It's a fixed obstruction that causes some degree of disability. An acute coronary syndrome, unstable angina being the least severe of all of the syndromes, is associated with an accelerated pattern of chest pain that comes on a lower threshold of activity or occurs at rest and occurs with greater severity and is more persistent. It is a change in that pattern that is of greatest concern.
Also, when I was a lad, Peter, we were told, if the chest pain was relieved by GTN, sublingually, didn't need to worry about it off home.
Yeah, I think life has changed. We used to use it almost as a diagnostic tool in a way.
So there was a reason why they didn't come back?
Well, there was a reason. They often didn't survive. And therefore we'd like to change that. And that's the whole theme, really, what we're discussing tonight, that GTN is not an absolute test. It will give you false answers and should not really be part of a comprehensive assessment. And people with chest pain, A, deserve a comprehensive assessment, B, deserve a management program focused around that person and significant follow-up appropriately.
So give me the symptomatology.
We still have classical...
Yes,
we have the classical symptomatology of crushing chest pain, someone squeezing, sitting on your chest, radiating to your neck and to your arms.
But that's not the majority of cases, is it?
No, when it does occur, because it's so classical, and if it's backed up by ECG changes, it's there, it's in front of us, and in a sense, we then know what to do, which we can talk about later. It's the
panic.
atypical
That's what you
ones.
do. Panic, don't you?
Well, we do panic sometimes, but the whole point is to have the right underpinning, the right process, and ability to handle a problem.
So that's the classic one, but women in particular don't present classically, do they?
No, the women may be different. They may describe the pain differently. Some people use different words. We take the word sharp to mean a piercing type pain, but some people just mean it's a measure of the severity. But really the message these days is any chest pain at any age should be taken seriously. You should evaluate that person carefully from their risk factors, their likelihood of having underlying vascular disease, and take care in those situations and not dismiss it.
Including right-sided chest pain?
Absolutely. Certainly chest pains that come on with exertion or occur at times of emotional distress. Those pains are when one's heart rate is up, no matter where the location of the pain is on the person's body. It does suggest an ischemic component. So
we'll let you off pain of the toe, but apart from that, yeah.
Certainly pains anywhere above the diaphragm, but,
yes.
but into the jaw and even around the ears and neck. So really we should pay a lot of attention to the pattern of the pain, whether or not the pain comes on with exertion when people are hurrying up hills or stairs. Those sorts of pains can often be a precursor to a more significant pain of that nature that is a signal for an acute coronary syndrome.
And so it's becoming protocol driven.
Absolutely, yes. And that's to ensure that there's a sort of consistency across the board so that you can actually rule out or rule in what needs to be done here. You always assume that someone who presents with chest pain, your first assumption is that they have some degree of acute coronary syndrome, be it that they're having a ST elevation AMI, or it's a non-STEMI or non-STIAC, or say a stable angina. You would just assume it is until you can rule out. You go through the protocols, the guidelines, to ensure that you're giving that person sort of the optimal opportunity to receive sort of intervention.
And Barry, in Aboriginal communities, Aboriginal Torres Strait Islander communities, tragically, this is a situation which occurs 20 years before it does in the non-Indigenous community.
Yeah, that's right. The gap in life expectancy is around 17 to 20 years. And so having chronic diseases, diabetes, heart attacks, 20 years earlier than the rest of the population.
And in terms of the expression of the symptomatology, is it at all different in Aboriginal Torres Strait Islander communities than it is in the non-Indigenous community, or is it the same deal?
Oh, well, the symptoms are the same, but what isn't happening is people recognising that the nature of the chest pain is cardiac related and thinking that it's a severe bout of heartburn or
so they find another excuse for
or
it.
Something like that, yeah.
Which indeed, Peter, happens in the non-Indigenous community. What people take an average of 45 minutes to an hour to recognise that this isn't just.
They do, and that's why, as we were discussing amongst ourselves earlier, that having a publicity campaign to make people more aware is a very key component of managing heart attacks, to use that word, because if people don't recognise and present for care, it's very difficult to do much.
What are the precipitating factors for acute coronary syndromes? The acute coronary syndrome.
Well, I think that's in some part a little difficult to answer. There are certainly some, there are the traditional risk factors that we recognise. This is a disease that occurs throughout the Western society and increases as we get older. And that's because of increasing plaque in the coronary vessels. So the traditional risk factors of blood pressure, hypertension, those
are the background factors.
The precipitating factors, however, are less clearly identified. We have actually ourselves performed a study where we looked at about 300 patients presenting with an acute coronary syndrome. And of those patients, about 20% of them had a clear precipitant, such as an infection or extreme physical exercise that they weren't used to. And we've even found that there's a small association with eating fast foods.
Really?
So, yes, within the subsequent 48...
Eating fast food fast or just eating fast food?
Just eating the... Well, what we actually looked at was we looked at the patients and whether or not they'd eaten a recognised meal from a recognised fast food chain, such as McDonald's or Hungry Jack's or so on and so forth. And in the 48 hours prior to their presentation, there was a 6-fold increased risk of myocardial infarction compared to their usual.
So you think the sort of globules of fat lodging in the coronary
and certainly
arteries.
there is some evidence to suggest that, in fact, it does change the way your vasculature responds.
Let's have a look at some ECGs just to remind us what we're talking about here, Derek.
Absolutely. So this is if you like, the changes that we see in acute coronary syndromes. There are three changes here, but direct you to the top left-hand corner. That's obviously a normal ECG tracing. You can see the QRS spike and followed there by the T wave. And the segment in between, of course, is the ST segment. And that's the most important area that we focus on. If you look across then, the ST elevation is an elevation in that ST segment. This is quite a marked degree of elevation. All you really need is 1 to 2 millimeters of elevation in that territory. And that correlates best with a transmural myocardial infarct. If you go to the lower left...
But it doesn't have to.
But doesn't have to, actually. If you actually look at the lower left corner, that's ST segment depression, and you can see that the ST segment is below the isoelectric point before the QRS. The important thing to recognise, though, is that patients presenting with ST elevation or non-ST ST segment depression, they have the same long-term mortality risk. The last change on that ECG slide was that of T-wave inversion, and those people are at increased risk compared to the normal population, but their risk is not quite as high as those with either ST elevation or ST segment depression.
And we also have a coronary angiogram to look at the anatomy.
Yeah, absolutely. This disease is really obviously a disease of the epicardial coronary vessels, and angiography has revolutionised our understanding and our care for these patients. And you can see in this short film that the artery running down the front of the picture straight down is the left anterior descending artery, and in this person they have a very large circumflex artery that is arcing a little bit to the right and then down underneath the other vessel, and that's the left circumflex that supplies the lateral wall and also the inferior wall. And you can see tight narrowings in the top of both of those vessels that is really coronary plaque, and that's the underlying pathophysiology of an acute coronary syndrome. In this person, given they have a very small right coronary artery, this is a left main equivalent, so quite a severe and quite a significant degree of narrowing that is of great risk to this patient.
So, Sue, the difference between a STEMI, a ST elevation myocardial infarction, and a non-STEMI, in practical terms, is really, we'll come to the diagnosis using troponin in a moment, but it is really that you would give thrombolysis in one and not in the other.
Absolutely. That's, at that point in time, when you've got an ECG that's got nice obvious ST elevation on there, that's telling you there that you've got it there, the non-STEMI. You've got to wait for your cardiac markers to come in. You're actually just looking at your, so that you're not going to thrombolyse that person.
Why, if you've got somebody who's got no normal ECG, but clearly from their troponins, Derek, they've got an MI, they've got myocardial damage, why wouldn't you give them thrombolysis? Is it just that the trials haven't been done?
Essentially, this is if you like, a mistake of history that we've treated ST elevation myocardial infarction.
So thrombolysis came before our understanding of myocardial infarction?
Absolutely, that's exactly the point, that ST elevation was very much a specific marker of whether or not the artery was occluded and that the patient would benefit from it. And we didn't have troponins at that time, and so people with ST segment depression included those with left ventricular hypertrophy and other previous changes on their ECG that have clouded the populations that got into the studies. However, if you actually apply the principle of early invasive management to these patients, you can see a benefit with ST elevation or without ST elevation. So the paradigm of fixing the plaque, you're correct, is associated with the benefit. It's just with thrombolysis, we've never gone back and revisited the studies about whether or not you can randomise patients on a positive troponin and some stark ECG change that's not ST elevation.
And if you've done thrombolysis, is it a problem for you want to go on to do percutaneous intervention? You want to go and do angioplasty, balloon angioplasty, and say stent? Is it complicated?
It is and it isn't. It's only complicated if we're doing it in the very early phase after it, and really in those people the risk is clearly warranted. So let me go back again. In somebody who has had an ST elevation infarct and then has ongoing pain and gets thrombolysis but doesn't respond to that thrombolysis, their risk is very high. And while the angioplasty and stenting is associated with a greater bleeding risk, the benefit is clear in that population. In patients who then routinely have an angiogram after their thrombolytic, say 24, 48 hours down the track, their risk is much the same as anybody else.
So, Peter, take me through the protocol. What is it that you do? Somebody turns up in the emergency department, or indeed if you're a remote general practitioner in a small country town, they might turn up at your surgery. Not necessarily the best place to be, but that's what they do.
Yeah.
What's the protocol?
Okay, well in fact you made the very point there. If you're in your surgery, you would take them to the nearest hospital because you have to anticipate that they could arrest and need defibrillation and intervention. So that point is, yes, these people should not be at home. They should be ideally where there is a degree of good support available. The first thing is to recognise that if someone has chest pain that in any way could be cardiac in basis, you take a good careful history, you evaluate the person. If they have ST segment elevation of a proven...
So 12-lead ECG?
Pardon?
You do a 12-lead ECG?
Yes, 12-lead ECG, you do their blood pressure, you do as many obs as you can, you put IV access, all of which in case something goes wrong. A 12-lead ECG and a troponin. Troponin takes maybe 8 hours to increase and may increase up to a maximum of 15 hours.
And there are kits now available for small
In South Australia,
hospitals.
we've now got those in every of the 64 country hospitals. They're easy to use. You need a half a ml or less of blood. You get the answer in 12 minutes. It's the same machine as used in the laboratory.
And how often do you do your serial troponins?
Any person who has chest pain that you're uncertain about should have serial troponins.
How often? What's the interval?
If the clinical case is stable and the pain has gone away, we may wait 8 hours. If the pain is changing, if clinically it evaluates it, we may well repeat that at 4 or 6 hours and multiple ECGs. One error is not to do enough ECGs and to assume that one normal one will always be normal. So observation, evaluating that person very carefully. If it's proven to you it's a STEMI, you go on with the thrombolysis unless there's a reason not to. And the thrombolysis should ideally be achieved within the first hour and even 90 minutes if you can, but the sooner the better when you make the diagnosis.
And so, I mean, people talk about door to needle time, so these are things that really happen very, very quickly within minutes. Yeah. And so within minutes you know whether or not you can give thrombolysis.
Sue was saying that they aim for 10 minutes at her hospital, which is a very high degree of excellence. Most hospitals are happy to make it under an hour, and half an hour is considered average.
I'd be happy to come to yours, except it takes me 12 hours to get there.
It's a safe place to travel.
So thrombolysis, what are the contraindications to thrombolysis?
Basically, it dissolves thrombus. Therefore, if someone's had a recent operation, they've got a potential for dissecting aortic aneurysm, they've had an intracranial hemorrhage, they have severe uncontrolled hypertension, anything which puts them at risk in bleeding into an area that you cannot control, a peptic ulcer that could well be bleeding. If someone wants to bleed and you can put pressure on it, that's fine. But if you can't, as in areas I've discussed, then they can potentially die. And you need to have a quick but focused discussion with the patient upon what you evaluate their risk to be and try and convince them on a risk benefit that it's worthwhile, if it is. Most patients respond well, and in some cases the ECG will return to normal, which is gratifying.
Okay.
Certainly, when one grows up as a medical student and a young doctor, one always fears the risks and complications of fibrinolytic therapy. But it's important to recognise that the risks of withholding therapy is actually much greater than the risks of giving it. The risk overall is about a 1% risk of stroke. The mortality benefits far exceed that, and I think that we need to be mindful that while the contraindications to fibrinolysis are certainly present, and Peter has listed them quite well, these are infrequent and one shouldn't fear administering fibrinolytics.
But we've missed out aspirin.
No, we haven't, because we gave it to the patient. No, every patient, if you think they have an acute coronary syndrome, should be given aspirin unless they've got a history of anaphylaxis to aspirin. That's the first line treatment, and it's really the benchmark that we do. If we're trying to use thrombolysis, we're trying to dissolve a clot on a plaque which is there. If someone we think is having a cardiac event, but there's no proof of that in the ECG and the troponin's still negative, then I like to think we put that person into an environment which is least likely to allow for further clotting to occur, and we use such things as aspirin, clopidogrel, Clexane, tirofiban, Many of those medications are available throughout the country.
Just
and can be
disabled their entire clotting system.
Well, that's right. But because we don't want that 2 millimetres of clot to occur and tip the balance from between a viable heart to a dead heart.
And Barry, in Queensland, ambulance officers give thrombolysis.
Yep, they can.
And you're giving it, and it's been given in remote communities as well in Cape York.
I'm not sure about that, but I can see the benefit of them being able to do that, given that that door to needle time you're talking about can be over an hour.
Now, is there any benefit over thrombolysis of actually putting a catheter in and opening it up and sticking a stent in?
Large-scale clinical trials, Norman, have demonstrated that there is a benefit, but I think that we have to recognise that that benefit is actually quite marginal. That if we actually look at that benefit compared to...
Well, that's a lot of Mercedes leases going south, isn't it?
Absolutely, that's true. And certainly the risk benefit is probably slightly in favour of primary PCI, but it's taken 20,000 patients to prove that there's a benefit there. And so if you think about it...
So don't agonise.
Exactly.
If
you're going to do something, if you have that as your only option, that you should get on and do it.
Do you use low molecular weight heparin in...
Absolutely, yes.
Is there any evidence for that, Clexane, enoxaparin, Derek?
Certainly. In patients who have ST elevation myocardial infarction, there is a small incremental benefit with the reduction in death and recurrent myocardial infarction if you use enoxaparin over standard heparin in a group of patients who may not rapidly get to an angiogram. However, if you actually look at the data for heparin alone, in non-ST elevation myocardial infarction and ST elevation myocardial infarction, the evidence is a little bit more marginal, and certainly in the non-ST elevation group, it's hard to prove that it does very much in the absence of angioplasty and bypass surgery.
And at what part of the process do you start on the classic post-myocardial therapy? I mean, do you start an ACE inhibitor at the same time as you're starting all that, or are you just going to sit and wait, not get too complicated here?
One shouldn't get too complicated, but the evidence obviously is that the aspirin starts even before the fibrinolytic or any angioplasty. The evidence for a statin is that there is some early benefit. It's been hard to prove that it's a huge early benefit, but there is early benefit, and I start that after I've written my notes for putting the stent in. I start the statin immediately. There were studies early on that showed that the benefit of an ACE inhibitor, it was there, but not on the first day. So usually we start that the following day. Clopidogrel, we start early, obviously, in the context of both angioplasty and fibrinolysis. But the data for beta blockers is diminished a little bit in the modern era. A large-scale study showed a slight increased risk of heart failure and cardiogenic shock in the routine use of that. And so, but there is some benefit with reduction of recurrent arrhythmias with longer use therapy. So the US and probably the Australian guidelines will soften that recommendation.
So what do you do about shipping people out? What are your criteria here? Does everybody with acute coronary syndrome get shipped out eventually?
No, they don't. And I come from a hospital that's actually 100 kilometres away from tertiary facilities. So I have the benefit of actually having a time frame that we can actually achieve getting people down for a urgent rescue angio. But that doesn't always happen. We certainly look at the patient. We look and see if we can, if they meet the criteria for angio first. That's what we'll go for PCI first. We'll go for that. But it's not always easy to do. And hospitals further and further away from the tertiary centres have a harder and harder problem. Retrieval is the issue. It's a big issue, certainly in Victoria.
So if there's no difference, why not just give thrombolysis?
Because, at this point in time, the recommendations and the protocols do suggest that, that the gold bar, the best standard is the PCI. And if there's an algorithm that the National Heart Foundation has put out.
So it's up to getting a helicopter in and out?
And helicopter, an ambulance, lights and sirens going down to see what you do. But if in my area, neck of the woods, Orbost is, it's got to be 6 hours away from a tertiary facility that can do something there. That's a long time to wait to see if you can get them down there when, doing fibrinolysis is going to be a much better option for them. You've done too much damage if you sit there and wait. So it's a
So what are you looking for? What do they call it? Timmy, what are you looking for the thrombolysis to say, well, we're in control here, you don't actually have to go to Melbourne?
I think if you can't make a decision in that first 30 minutes, you know, and you can't find someone to pick this patient up, and that's going to be the thing. South Australia, we were talking earlier, has much sort of better developed networks than we have, and they have a system and protocols, and they know they're discussing it with their tertiary hospitals from the go-get. It's an established network. Victoria, that doesn't exist like that. Sometimes it's a bit of a cat and mouse game trying to find a facility to actually pick them up. Weekends, you know, 3 o'clock in the morning. Not everybody's willing to sort of say this person is someone that I want to do it. If you phone up and I've got an 89-year-old lady here, no, I don't want them, you know, and so we have to make a decision quickly which way we're going to go.
And what are you looking for?
Well, what we're looking for, Sue's point is well made, and luckily in South Australia we've had a very enthusiastic network developed where 24/7, at 2 minutes, I can get any cardiologist like Derek on the phone to advise what I'm doing with the patient. So it's a joint manager of the patient on the criteria which we've discussed. Patients need to be treated then. There needs to be a management plan constructed which could include urgent transport to Adelaide, even for rescue PCI after thrombolysis or for primary PCI.
And that's what I'm getting to. With thrombolysis, you're looking for a reduction in the ST elevation and chest pain going. Is that what it is?
You would like to see that. That's the best possible outcome, in which case you could assume that there has been a revascularisation, and although that person should then have interventional assessment, it isn't as urgent as needing to go down for the next 2 hours. So I would then ring, in our case we call it ICC net, and someone like Derek would agree and then say, fine, I'll organise the bed and transport for tomorrow or the next day, and that happens. If someone comes in who's urgently unwell and needs to go down straight away, I'll ring the same number, the same advice, we discuss it, work out what to do, and Derek again will organise the bed and hospital and transport at that time and the helicopter and everything, and the patients go down.
Let's take some questions from Marissa Pillar in Cairns. I've read that using high-dose lipid lowering after acute coronary syndromes gives worse outcome. Is this true? We've kind of covered that.
Certainly it's not true. This was formally studied in a study called I've got a mental blank on which one it's called. The Prove It study used a weaker versus a stronger lipid lowering agent, and those who actually had a stronger strategy had a lower rate of recurrent myocardial infarction and death, as well as stroke. So that data has never been validated it's been proven to be wrong, basically.
And another question, is it common now for patients to come out on clopidogrel plus aspirin, and if so, is that due to concerns about aspirin resistance?
Aspirin resistance is an interesting and difficult to define phenomenon, but that's true. The data is that patients who receive aspirin and clopidogrel have a lower rate of recurrent myocardial infarction, death and stroke at 12 months, about a 20% reduction. And so some people have defined aspirin resistance as people who have an event while taking aspirin. There are many sort of subclinical or laboratory definitions of this. From a functional level or a practical level in the clinical practice, we know that plaque is active in the first 6 to 12 months after an infarct, and dual antiplatelet therapy is clearly associated with reduced events.
And a nurse in rural Queensland asks, are there contraindications to giving thrombolysis in indigenous populations?
This was probably a reference to streptokinase, which was the original one used, and because of the high incidence of streptococcal infections in the indigenous population, there were significant allergic reactions, and certainly if you gave it to someone, you couldn't give it again within 12 months in a general population, and the main benefit was cheap. It cost about $200 or $300 as opposed to roughly $2,000 a dose. Now, the cheapness, however, has been outweighed by the problems and its inefficiency, and so it's not now used. But the other...
So recombinant thrombolytic agents are the way to go. And are there any instances where ST elevation would be treated conservatively in a remote community? What do you think about that, Barry? In other words, not much done.
Well, I think, given the incidence with Aboriginal populations of high chronic disease at a lower age, and generally most of them have comorbidities, I think they automatically, basically, in a high risk category, and action should be taken.
Do you get much resistance to people going?
You get resistance to people wanting to go to the clinic in the first place because they're not sure the cause of the chest pain, but when they do turn up, there is resistance for people wanting to leave the community and go down to the larger cities. Because usually it has to happen really quick and it's sudden, and they want to talk to their families and that sort of thing.
And any techniques for cajoling them to make the move?
I reckon you just be straightforward and be direct, just say it like it is.
And they'll take it up. Another question here from the same nurse in rural Queensland. How reliable are stat troponin kits?
Oh, they're highly reliable. They've continued to evolve. We've had troponins now for over 10 years, and the assays have moved on to the 4th and 5th generations. And the assays themselves are excellent. There is a very low rate of false positives and a very low rate of, obviously, false negatives. So they are, the point-of-care tests have evolved, I think, to become a real standard of care and something we can base management on.
And we've got a graph here, haven't we, showing the success following troponin introduction?
Yes, that's quite right. In fact, I was just going to say that troponin mechanism we use is exactly the same quality standards as the laboratory, and they're interchangeable, so there's no benefit in having to send it away to a laboratory to get a better answer. About a few years ago, it was looked at in South Australia and realised that there was roughly twice the mortalities of in-hospital patients with acute coronary syndrome in country beds as opposed to city metropolitan-based beds. A program was evolved focused around having troponin on site, a correct methodology for assessing and interpreting that supported cardiology intervention, as we've discussed on the phone.
Let's have a look at the graphic. There's a graphic to go with that. Yep,
good. And I hope the graphic will point out that the coronary deaths now have come back to exactly the same as the metropolitan area, with the evolution is from 97 through to 05. The red line has now come down to meet the blue line, which is a metropolitan death rate of patients in hospital with acute coronary syndrome. And this has all evolved from an integrated approach dealing with a troponin, correct ECG assessment, correct support by cardiologists, backed up by correct transport, all organised smoothly and efficiently, and that's the outcome, which is nice to see. And
that's South Australian data?
Yes.
Nice if it happened in other states as well. But
we're working towards it. I think that's what, benefits.
Another question from a general practitioner in rural Victoria. How effective is oxygen administration in an acute cardiac event? Seems to be given to everybody, Sue. Well,
absolutely. I mean, it's from the point of view that that's probably the first thing the patient receives is the oxygen when they come in there. I mean,
but does that make the nurse feel better or the patient?
Well, I think it makes the patient feel better. It makes everybody feel better. But the issue is that where you're having chest pain because there's not enough oxygen going to your myocardium. So, I mean, oxygen obviously has a role to play in
I see an evidence-based smile on Professor Chu's face. Has anybody looked at
That's interesting. It has never been studied thoroughly in an acute coronary syndrome setting. And I did notice recently, looking at the NICE recommendations, that they've watered down the UK recommendations. They've watered down their recommendations about oxygen.
They just can't afford it.
Exactly.
That's why they're
it's expensive.
Smokers, they place the place to blow up.
So it may work, it may not.
It does. Well, I've certainly, witnessed, and I'm sure everybody else has, the patient that's been in your department, and they're pain-free, but just the pain just starts to tickle back again there.
What does oxygen do to your coronary arteries?
It actually causes vasodilatation of your coronary vessels.
Oh, that's a relief.
Yeah, so it's a good thing.
So you're not doing any harm?
No, certainly not doing any harm.
Oh, that's good. Let's go to our first case study. It's John, who's 66 years old. He's overweight, he's a retired policeman. He's actually got a history of coronary artery disease, type 2 diabetes, and he's got a leg ulcer on his right leg. He's on a fair number of medications. He's on aspirin, he's on antihypertensives, he's on oral hypoglycemics, and he's on a statin. Comes to a remote health clinic to see you, Sue, with central discomfort going up to his jaw. It started on his morning stroll and it was relieved with GTN, but it's come back.
And so he's come back in the door. I mean, we're hoping that as he comes in the door, oxygen, weigh them. If you can just get someone to step on a set of scales as you're getting them onto a bed, solves a lot of problems later on. Aspirin, up on there, and ECG, cardiac monitoring.
Weighing them because your dose of thrombolysis.
Absolutely. I mean, the tenecteplase now and all those doses are worked on, weight calculated. So that 30 seconds or less that it spent on a scales makes a big difference later on. But yeah, Up there, IV access, ECG. Take your ECG and have a look. Now, this guy has got a lot of risk factors there. We've, he ticks all the boxes as we spoke about before, and so you've got to assume that this gentleman has got some degree of acute coronary syndrome going on there.
Let's have a look at his ECG. So he's got a flipped T wave.
Yep, inverted T waves going on there.
This gentleman would clearly potentially have an angiogram, much like the one we've shown you already, actually. He's got changes in most of his coronary vascular territories there, so he is at increased risk. I would be at pains to point out, though, that whenever we assess patients with chest pain, and I wonder two things. One is, does the patient have the disease, and two, is that disease symptomatic right now? And in this gentleman, being a diabetic with leg ulcers, we know that he has the same risk as a person who's already had an acute myocardial infarct. And so I would treat him as if he already has the disease, and with the ECG now, he certainly, I suspect that's symptomatic as we speak.
But you can't give thrombolysis on that basis?
Certainly not. There's not sufficient ST elevation. There is certainly changes suggestive of ischemia, but not ST elevation sufficient to thrombolyse him based on that.
So you do your troponins?
Absolutely.
And if they're normal?
If they're normal, we're going to monitor serial. Once again, we're going to do serial troponins we talked about before. Does he become pain-free? Can we control the pain? You're going to sort of manage that patient depending on what happens after you.
And if the pain goes away?
Pain goes away, repeat the troponins, pain-free, pain goes away, your GP physician...
And if the pain goes away and the troponins go up, what do you do next?
Well, then we're looking at an on-STEMI. So we know then that we've actually got myocardial damage, so we've got to actually look at some aggressive medication therapy. We talked before about clopidogrel, enoxaparin, torafibins, the GTN infusions.
But even so, according to Derek, his chances of having ventricular fibrillation in the next 72 hours are as high as if he's had a STEMI?
Potentially, so we're not going to let him go home. He's going to stay put with us, or transfer out to a facility that can look at doing an angio.
And how important is that?
Well, I think that the way, again, to think about these patients is not only what risk they're at, but what residual risk can we salvage in this gentleman. This is a man who we already have established has got extensive, or is at risk of a coronary event, who's got some ECG changes and thankfully hasn't got a positive troponin. So we know that he's threatening to have an infarct, and we can potentially prevent that event from happening with some judicious use of thrombotic therapies early on, and transfer for angiography and definitive revascularization as the anatomy determines.
And dual platelet?
Yeah, absolutely. In the first instance, dual platelet platelet therapy being aspirin and clopidogrel.
What about other cardiac markers?
Well, we have several cardiac markers emerging through research. One is BNP that might already be available in some places. The BNP is much more associated with left ventricular dysfunction and therefore is useful for assessing breathlessness. There are other markers such as ischemia-modified albumin that are still tools of research. The important thing to point out about troponin, though, is that it's not just a marker of risk. It is a marker that one needs to do something different, i.e. this person needs to go and have an angiogram, needs to have their anatomy defined and their treatment dictated based on that anatomy. And that is where troponin has really revolutionised the management of acute coronary syndromes, because it doesn't just tell us that we're at risk, it means that there's other things that we should do.
And Peter, I suppose it means that you're also meaning that this person doesn't move far away from a defibrillator.
Well, in the urgent context, yes, I think you're right. In fact, if he presented this way, it would be a sensible case made for having an early consultation with the cardiologist on call in Adelaide, in our case, to say, look, he's going to have to come down at some stage. What are we going to achieve by waiting in 6 or 7 or 8 hours in a hospital? Even if we don't have any absolute proof that he's having an acute syndrome, he's got the risk factor, he's got defined disease, he's going to have an angiography, and if we could manipulate the system to get him to go down early, before he defines, that would be sensible, rather than just waiting and observing and waiting for possible troponin rise where we are.
There was actually a very interesting study performed by a group of German investigators who looked at whether or not one should wait a long period of time and fill the patient up with lots of dual antiplatelet therapy and heparin and so on and so forth.
All the stuff you like so much.
Exactly. or treat them as well, but take them to the cath lab within 6 hours versus waiting 3 to 5 days. And in the group that they waited in, there was a higher event rate of death and myocardial infarction. And if you looked at when those events occurred, if you looked at the events that occurred after the angioplasty, they were exactly the same in both groups. So all the events that occurred of difference were before. So what we're doing when we're waiting is simply waiting for events to occur despite the therapies.
So if you can get early intervention, you do that. And things have changed in Cairns, haven't they? Barry, you've got intervention available locally now rather than having to go to Townsville.
Yeah, that's right. We have a new cardiologist from the UK's come over, and they've upgraded some of the facilities there, so they're able to do the PCIs on site there now instead of sending to Townsville or Brisbane, as the case was before.
So let's go to our second case study. It's Janine, who's a 40-year-old Indigenous woman. She comes to you, Peter, with hot burning sensations to her back and shoulders. She's not been feeling that well over the last couple of weeks, tired, maybe a bit feverish. And the pain comes on when she exerts herself, like hanging out the washing, and that's what she was doing about an hour ago when all this happened. Her weight's about 82 kilos, she smokes about a pack a day, and she works part-time at the local council. She's not on any medications.
Well, she's in a very high risk, as Barry and I have discussed before. She has an Indigenous background which puts her in a significantly high risk group. It's added to by the fact that she smokes, and there may be a question of a late presentation with having had some odd symptoms this last week. She needs careful on-the-spot assessment, troponins, bloods, ECG, and depending upon that whole context, you will then discuss with her recommendations that you would make, and it would be a case of trying to convince her that she is at risk and trying to convince her that she is best to be able to go somewhere for further treatment.
So the pain goes away on GTN under the tongue, and her troponin's negative.
Right. Well, she still retains all her risk factors. I would place her into a category of possible unstable angina, and I personally would want to have her transported down for urgent assessment. We do have time. The pain has gone, troponin's negative, and therefore the myocardium isn't damaged at this stage, and it would be, in our context, we would arrange for her to stay in hospital and to go down within perhaps a 2-day time frame. That would be speeded up if she had further angina, etc.
I mean, this woman, Barry, is not necessarily going to feel that comfortable in a hospital. I mean, none of us feel comfortable, but if she's from a local community, she's not necessarily going to be that happy being in hospital, and then certainly transported even further away from home.
Yeah, that's right, but the point is, it could be a life and death situation, and that's what has to be made clear to her, that, you're in the right place to be having a heart attack.
I just add there, Norman, sorry, that by using the family and depending upon the particular relationships and the cultural aspects, often decisions that can be shared with her permission and can help to get you to where you want to go. It depends very much on dealing with the appropriate way that local people would like to be dealt with.
Yeah, that's right. There may be some decisions around people that she has to talk to about the surgeries, and whoever goes with her will have to be someone who they can discuss that decision with, and it's best that it's somebody, an adult, an escort who is allowed to make that decision. Can't just be anybody.
Of course, women are often relatively ignored in this situation. People don't believe it's cardiac. I mean, we believe it's cardiac because we're doing a program on chest pain, but...
Absolutely. I think that it's a multitude of factors that contributes to that. Women often experience slightly more atypical type symptoms. Their pain, when they do experience it, if it resolves rapidly, or if they're often slow to present because they've got to do the dishes or the clothes or look after, they're the carers in our community, and they're more often attending to those tasks. And with delayed presentation, their symptoms often resolve. So we know that they often get, well, I wouldn't say neglected, but they get overlooked is the view that probably occurs more commonly than they should.
So Janine, her chest pain comes back, and so she's shipped off to the nearest town where there's a hospital, and by the time she gets there, she's had chest pain for about 90 minutes. Let's have a look at her ECG when she gets there.
The ECG there shows significant changes in the left part of her chest, V1 through to V5, and it would be very consistent with the angiogram that we saw earlier with an obstruction in the
But her troponin's still negative.
In which case...
It's a great
That's
thing.
good.
It's a good thing.
It's a good
Yes.
thing.
Yes, we've got
It
time.
means that so far, first of all, we must remember troponin does take a few hours. It is not instantaneous. She may well have suffered damage, but it will become obvious in 4 to 6 to 8 hours. But either way, she's got definite marker for us to do something about it, and that will depend upon what facilities we have at that hospital.
Now, she's been going all day. You know, she had it this morning with putting out the washing. She had it again just before she came in, and now there's 90 minutes till she gets into town. You're well beyond your door-to-needle time, aren't you, with this woman?
That depends on taking a very careful history. It may well be, with dissecting the history out, that we do conclude that this, in fact, is a recent event for the last 90 minutes only. That would be supported by her initial troponin if that was negative and then remained negative. Then if we checked back 6 to 8 hours prior to those times, we can actually hopefully get a fairly...
She started infarcting quite recently.
Yeah.
I think it's also important to point out that troponin isn't part of the thrombolytic algorithm. We don't wait for a troponin to decide to thrombolize somebody. So I would hope that with the recurrent pain,
you treat the ECG.
You would wait for you would obtain the ECG, and if it showed ST elevation, then I wouldn't be waiting the 12 or so minutes for the troponin to come back. I'd be getting on and treating her.
And if she's big hypotensive, her colour's bad, even on oxygen?
Well, certainly in those situations, if you have primary PCI available, which is infrequently the case in this context, that is a preferred option. But nevertheless, if you don't have PCI available, then you must do something, and that is thrombolysis.
She may be at risk, certainly, but she's certainly going to be worse if you do nothing. The critical thing with cardiac management is do something. Something is always better than nothing, and what you do is situational.
What's the risk of transferring her post-thrombolysis?
You generally have a window.
Do people die in transit?
Generally speaking, the arrhythmias of the reperfusion process occur over the first hour after. Usually they're self-limiting, and most people would prefer to transport people ideally beyond that time. On the other hand, a properly equipped helicopter with someone who's connected to a defibrillator can do just the same that we can do on the ground. I perhaps ask Derek what he thinks.
Well, certainly the overall risk of thrombolysis is, and the arrhythmias after that is relatively low. So, for example, the French and Queensland system of drip and ship thrombolysis in the field, they're being transported immediately, and the risks are not particularly high, certainly not from a bleeding point of view. And as long as you're close to a cardiac defibrillator, then all of that is fine. From in the country where you might be somewhat restricted from a resource point of view of not being able to ship everybody, I try and take the attitude of thrombolyze them and plan for failure, i.e. look for whether or not they're going to reperfuse. Failed reperfusion is marked by ongoing chest pain, hemodynamic compromise, and or a failure to reduce the ST elevation by 50%. Those criteria...
So you've already called out the transport?
I've warned the transport that we're going to potentially want them. We repeat the ECG at 90 minutes. If they've got ongoing pain and don't meet a reperfusion criteria, we press the button and on they come.
Right. Peter?
Yeah, I would agree. This is the one benefit with having an integrated transport and assessment system. The transport people discuss with the assessment doctors, either the cardiologist and or the GP, so it's a coordinated approach taking into account all those issues.
What happens in Victoria?
In Victoria, we haven't sort of got those networks established.
So you beg a lot?
We do beg a lot. It requires, the doctors that you've got there to pick up. You basically sort of try and look at your corridors of transport.
So is Geelong your nearest?
No, in Warrigal we're down to Monash Medical Centre, Southern Health. So we'll start there, and then you work your way across and see how you go. So yeah, you try and, and there's certainly a lot of talk. The networks are trying to get themselves up and established. The South Australian one's been talked about a lot, and there is a lot of, there's 35 emergency departments all sort of trying to get on the same page about how we look at getting people to the best place they can be.
I thought the Victorian system was the model for the nation.
On the grounds that I might lose my job, I'm not going to say anything.
Barry, what's the Troponin model? You've developed a model of cardiac care in your community-controlled service.
Yeah, well, we've combined the phase 2 and phase 3 there. So phase 2 is about the monitoring the recovery and a graded exercise and education program, and phase 3 is more about maintenance and self-management. So we've come up with a program that does those two things together.
So it's trying to prevent a second event and getting people back on their feet.
Yeah.
And that's integrated, what, with cardiac rehabilitation nurses in town, or what?
Yeah, we've set it up so that it's a collaboration between the coronary care unit and the cardiac rehab unit at the local base hospital and the local Aboriginal Health Service. And they come out and do similar sort of thing, similar sort of activities they do at the base hospital. And the next step after that recovery phase is we try and ensure that people eligible are signed up for a GP management plan and that they're monitored over the next 12 to 18 months.
And Derek, the evidence is very strong for cardiac rehab, isn't it?
It certainly is. Meta-analyses would suggest, so combined studies of several groups would suggest about a 15 to 20% reduction in the risk of mortality associated with cardiac rehab. The big shame in Australian cardiovascular care is attendance to cardiac rehab is somewhere between 20 and 40%. Most, even in metropolitan Adelaide, it's
so
only
done
around
all this hard work, and they die of a second MI.
It's very true. And the very sad thing about it is, if you look at the people who have had a previous event and look at their time to arrival to hospital, it's no shorter than the person who arrives with their first event. So our education isn't getting through.
Barry, you were going to say something?
Yeah, National Heart Foundation statistics a couple of years ago was indicating that 93% of Aboriginal Torres Strait Islander people eligible didn't attend a cardiac rehab program.
So like everything else, you're undertreated?
Underdiagnosed, undertreated.
So, well, Peter or Sue, what do people go home on? What's the evidence-based treatment for post-myocardial infarction, whether it's STEMI or non-STEMI?
Oh, well, did you want to...
Oh, you're an ED nurse, you
I'm
don't
an
care
ED
about
nurse,
that.
so I actually I bring them in, I treat them, I get
you save their lives.
I think it's interesting because this is another area that another part of the network I'm involved in is in fact focusing on this very point, and they've just achieved a consensus that every person who has an acute coronary admission at whatever part of South Australia will be given a standardised information and booklet when they go. When they discharge from Metropolitan Hospital, they'll be linked to coordinators in their home area in the country, and that coordinator, who may well happen to work in a doctor's surgery, will follow the patient and help to organise local rehabilitation.
But they're on an ACE inhibitor?
ACE inhibitors, statins and aspirin are the three critical factors. Clopidogrel, unless you want to have an operation, which is a problem, because some people with stents are asked to be on clopidogrel for all their life, but surgeons, when they want to operate to remove...
But if they haven't got a stent in, are they still on clopidogrel? Because
probably for the first year. After that, they don't always stay on that. But I understand the drug-eluting stents, and Derek could answer me more precisely.
You guys are putting in these drug-eluting stents and committing these people to this long-acting bloody thing.
It's true that about 60% of interventional procedures are associated with drug-eluting stents in Australia these days. But I think we need to focus carefully on the issue. Firstly, that the rate of stent thrombosis, which is the chief fear with the drug-eluting stent, is around 0.6% per year. But these patients have a recurrent event rate of 2% per year. So more events are going to happen from other areas in the coronary vasculature that require
it's easy
prevention.
to forget that you've only treated one little bit.
Exactly.
There's disease elsewhere.
So that's the first thing to say. The second thing to say is that for most operations, the surgeons... The surgical fear is bleeding.
Just on that,
yeah.
that emphasises the importance of post-cardiac care, because
Absolutely.
you have not fixed the problem with the stent.
All we have done is fix the culprit lesion. We have not fixed the disease, which is plaque in the coronary vessels right through the coronary vessel vasculature. So you're correct. The prevention, angioplasty has rarely been shown to reduce mortality. It's actually statins and ACE inhibitors and aspirin and clopidogrel that have shown that.
It's a large randomised trial which found that.
That's correct.
And lifestyle modification.
Yes. But if we turn to the problem of drug-eluting stents, one has to weigh the risk-benefit of having a recurrent myocardial infarction versus the surgical risk of bleeding in any operations. And most operations are not associated with a very high rate of bleeding, even with clopidogrel. It is just very much a routine fear that the surgeons have. When we've questioned them carefully, they actually can't quote their rate of bleeding. Having said that, there are certain operations which clearly are at associated in greater risk of bleeding. Neurosurgical operations and intra-abdominal operations are of higher risk, and one needs to consult their cardiologist about what the relative risk of stent thrombosis is. Not everybody's the same.
But you don't know, particularly when you put in more than one stent, how long you can, whether or not you can ever stop clopidogrel.
Well, the rate is actually very, very low for the risk of stent thrombosis. So you're correct, we don't know, but we also know the risk of restenosis as well, and it's a function of the diameter of the lesion as well as, or the vessel, and the length of the lesion you've treated. So in people with very long stents, the risk is much higher, and so we would be more reticent to let them stop the clopidogrel and aspirin. In people with a discrete stent, then I'm actually quite comfortable to let them discontinue the clopidogrel and or aspirin for the operation, but I would always maintain one of those in the longer term.
So, Peter, let's just talk about preventing acute coronary syndromes in the first, an acute coronary syndrome in the first place. GPs are still, 40% of GPs are still not using absolute risk tools. It's extraordinary.
It is, and I can't really give you an adequate answer because I can't speak on behalf of the people who don't. I think it is possibly a hangover from my generation that was brought up without the use and that perspective on life. In my day, preventive medication was an anathema, and you weren't allowed to look at people from that point of view, only to treat acute illness. Nowadays, the pendulum has swung, and certainly with my involvement with registrars and students and other people, the move is very strongly to emphasise risk stratification. And one of the simple other mechanisms of evaluating your coronary care in a practice is to see how many patients who've had coronary episodes are still on aspirin clopidogrel, how many diabetics are on aspirin, how many people have their statins under 4. So there are a lot more. I'm positive that with the mechanisms we have now, our computer-based tools that allows me to extract from my patients how many people fall into whatever category that I've just mentioned a few, it leads to a much more open evaluation, and I think there's a much growing acceptance that trying to prevent the problem is as important as treating the problem and preventing it occurring again in those groups. And
Derek, there's some evidence that you actually get a very rapid effect. If you put somebody with a high absolute risk on a statin and an antihypertensive, you actually can get a risk reduction within days.
Oh, that's certainly true. There have been studies that have looked at patients having their statins initiated in hospital or within days of their myocardial infarction, and showing whether or not that reduces recurrent events by 30 days. We know that the cholesterols drop reasonably quickly and their vasculature behaves better.
Calms down.
But the studies have been a little bit underpowered to demonstrate, but there is a clear trend towards a benefit in hard clinical endpoints by 30 days associated with high-dose statins early on.
So get in there with your absolute risk tools and put people on the program. What are your takeaway messages, Peter?
Pardon?
What are your takeaway messages for the audience?
Probably the first thing is to recognise, I think that's critical, you can't very well treat or assess if you don't keep your mind open to recognise that chest pain presentations may be cardiac, because an awful lot are not classical. React appropriately to the situation, whatever you have evaluated. We've discussed different levels of reaction depending upon what we're presented with. And the next thing is then put into place to either rescue or rectify the process. So we have to follow it up. So recognise, react appropriately, and if you want to use the word follow up or rectify that problem into the future.
Barry?
I'd agree. If you're experiencing chest pain and you're not too sure, get to the hospital, get help, and if you are referred to cardiac rehab, come along, because we can help you.
And you're living proof of it.
I am.
We didn't get down to that, but yes, we're glad to have you. Sue?
I think I'd like people to sort of acknowledge that the sooner that they get to a facility where we can investigate and initiate some sort of management, the better the outcome, and that hospitals and rural health services need to establish networks to try and sort of keep these pathways going. We don't all have the benefit of having someone like Derek sitting in our back room that we can call on. So we need to establish networks with other regional and tertiary hospitals to make sure that our clients have the best possible outcome they can.
Derek?
My take-home message is ACT. We've spent lots of clinical trial resources looking at the question of fibrinolysis versus primary PCI, and we've established that PCI might be slightly better. But for every life that we save for giving a person PCI over fibrinolysis, we would save 5 lives if we could get people treated within a more timely time frame, and we would save another 7 times those lives if we could actually extend fibrinolysis to the population of people who currently don't get it in Australia today.
Particularly those in the community, which means perhaps modelling the Queensland model with the ambulance officers being properly trained and giving it. Thank you all very much. It's been a fascinating, lively programme, and I hope you agree with that, this programme on chest pain and acute coronary syndrome. Our thanks to the Department of Health and Ageing for making this programme possible, but thanks also to you for taking the time to attend and contribute. And if you're interested in obtaining more information about the issues raised in this programme, there are, as always, a number of resources available on the Rural Health Education Foundation website. Visit it at rhef.com.au. To register for CPD points, don't forget to complete and send in your evaluation forms. I'm Norman Swan. I'll see you next time.